Three, two, one. We are live, sir.
Welcome to Experts Outlook Live webinar series. Good evening, welcome everybody. We have an exciting feast of scientific discussion today. I am Dr. Indranil Purkayat, General Manager, Medical Affairs, IPCA Laboratories. I welcome you all to this scientific evening. We have two eminent speakers from Nashik who are eminent KOLs, key opinion leaders in their respective fields. I would like to introduce them one by one. First, I would like to welcome and introduce Dr. Devdatta Shafekar. His presentation is benefits of azilnitidine from renal aspect. Now let us introduce Dr. Chafekar. He needs no introduction, but still, he's an MD and DNB in internal medicine, DM in nephrology, and also a DNB in nephrology. He's a fellow of many international organizations like ICP, ISN, ASN, ISN, and also he holds the fellowship of ISPD. He's a senior consultant nephrologist, Supreme Kidney Care. He runs specialist services in hypertension, kidney diseases, dialysis, and transplantation in Nashik. So welcome, Dr. Chafekar, to today's program. Welcome. Next, I would welcome and introduce Dr. Aniruddha Dharmadhikari. He's an interventional cardiologist of international repute. He's an MD in internal medicine, DM in cardiology, fellow of American College of Cardiology, and also European College of Cardiology. He is a senior consultant in Sri Sai Baba Heart Institute and Research Center, Nasik. Both of our speakers have numerous presentations and publications in international journals and has presented in many international conferences. So Dr. Dharmadhikari will present on the benefits of azilnitidine from the cardiology aspect. So I would like to welcome Dr. Dharmadhikari and request him for this first presentation.
Good evening, everybody. Thank you, Indranil, for a very kind introduction. I welcome my co-speaker, Dr. Trafficker, and the other participants in the webinar. Today, we will be discussing on azilnitidine, and I will be discussing about the cardiac perspectives of azilnitidine. We know that hypertension is a major public health concern all over the world. And these figures are really astounding. Close to 1 billion is the number of people affected with hypertension in the year 2000. Hypertension is a major public health concern affecting 26% of adults worldwide. There is expected to be a 60% increase in the number of adults with hypertension globally by the year 2025. That means the number of hypertensive patients estimated by the year 2025 are going to increase from the present 1 billion to 1.6 billion. 10% of all the global healthcare spending is attributable to high blood pressure and its related complications. The annual worldwide cost of hypertension is estimated to be around 370 billion. These are astronomical figures, and we definitely need to do the best we can to reduce this burden on the global society. Well, there are so many concerns about hypertension and their comorbidities, like coronary artery disease. We know that 50% of patients with coronary artery disease have hypertension. 15 to 25% of hypertensive adults have an increase in the left ventricular mass. 77% of patients who have a first stroke have a blood pressure of more than 140 by 90 millimeters of mercury. 8 to 15% of hypertensive adults have reduced renal function. 75% of added cardiovascular risk in diabetic patients is attributable to hypertension. And 74% of patients with peripheral artery disease have hypertension. So hypertension is at the epicenter of the new, not exactly new, but an epidemic which is growing in gigantic proportions. Well, there is an Indian study, the Mumbai cohort study, which determined the cardiovascular related mortality in almost 150,000 patients with different grades of hypertension. And it was observed that with from systolic BP 120 to 129. The number of deaths were 233. They increased to 333 with a 10 millimeters of mercury rise in systolic blood pressure. But they quadrupled from this baseline blood pressure. When the systolic blood pressure was more than 140, the deaths were more than 1,000. So that underlines the importance of hypertension in the increasing mortality. Similarly, there are studies which show that even a small reduction in blood pressure can reduce many of the complications and severe mortality. Just a 2 millimeter mercury decrease in mean office systolic blood pressure will result in a 10% reduction in risk of stroke mortality and 7% reduction in risk of IHD mortality. So that's a very significant impact of blood pressure reduction on mortality due to stroke and ischemic heart disease. The overall impact of reduction in blood pressure. Well, the stroke incidences will be reduced by 35 to 40%. Myocardial infarction will reduce by 20 to 25%, and heart failure incidences will be reduced by more than 50% by normalizing the blood pressure. Calcium channel blockers have been used since the past 60, 70 years in the treatment of hypertension. And there are various calcium channel blockers now available. In the year 1996, there was a classification of calcium channel blockers proposed on their onset of action, duration of action, their selectivity, and which type of channels which type of calcium channels they affect. So it is not necessarily according to the time frame of their development that they are classified into first generation, second generation, third generation, and at that time there was no fourth generation in 1996. Fourth generation has been added later on. So this classification is based on the mechanism of action of the calcium channel blockers and not the time frame of development. So the first generation calcium channel blockers, the examples are nifedipine and nicardipine. Both are L-type calcium channel blockers. They don't have any effect on the N-type calcium channels. The onset is rapid, the action is strong, the binding of the calcium channels is strong, and the duration is short. The uh, second generation, that is the benidipine and ifenadipine, they are also L-type calcium channel blockers, though benidipine to a certain extent has some effect on N and T types calcium channels also, but by and large it is a L-type calcium channel blocker. They have a gradual onset of action, strong binding to the channels, and duration is moderate. The third generation, which is amlodipine and azilnidipine, they are predominantly L-type calcium channel blockers. At that time, there was no description of the T-type calcium channels. So, azilnidipine does not have any effect on N-type, but it does have effect on the T-type of calcium channels, to which we'll come later. What is the significance of this blockage of T-type of calcium channels? The onset is slow, the binding is strong, and the effect is long-lasting. The fourth generation, the examples of which are cilnidipine, lacidipine, lercanidipine, they are L-type as well as N-type calcium channel blockers. They do not have any effect on the T-type of the calcium channels. The onset is slow like the third generation, binding is strong, and the effect is long-lasting. Now, coming to the other things, we'll just highlight the sympatho excitation with the first generation calcium channel blockers is the highest, and it goes on reducing with the generation. Also, the blood norepinephrine levels, they are uh, increased in the first and second generation calcium channel blocker treatment, whereas the third and fourth generation calcium channel blockers do not have any effect on blood norepinephrine level. Now, reflex tachycardia, which is the result of these first two things, is the highest with first generation, a little lower with second generation, and almost absent with the third and fourth generation calcium channel blocker. Now, I was talking about the effects on the norepinephrine and sympathetic stimulation. The first generation nifedipine and nicardipine, they cause a increase in plasma norepinephrine levels, increase the muscle sympathetic nerve activity. The second generation, no significant change. Amlodipine uh, is increased or no change, and with azilnidipine, the plasma norepinephrine levels, they are no change or reduced, and no effect on the muscle sympathetic nerve activity. So as I said initially, there are various types of calcium channels: the L or long-acting, N or neuronal, P Purkinje, Q R N T or the transient. Of these six types, three are clinically important for us: the L type, the N type, and the T type. The L type, the major effect is on muscular contraction. They are predominantly present in myocardium and smooth cells. The N type cause catecholamine release and they are present in synaptic nerve terminals. And the T types, they are post-synaptic nerve terminals and nodal tissue, that is the sinoatrial and atrioventricular nodes. And the major function is their effect on the pacemaker activity. They inhibit the pacemaker activity. The blockers inhibit the pacemaker activity. Now, the mechanism of action of calcium channel blockers, we are all aware of. So I need not go into the details. This is the effect of calcium channel blocker on the smooth muscle cells. It prevents vasoconstriction and leads to vasodilatation of mainly arteriolar smooth muscle cells. The effect of the heart of blockage to the calcium channels into the myocardial cells will reduce the myocardial contractility, will reduce the AV conduction velocity, and reduce the SA node pacemaker rate. So why do we need a new calcium channel blocker? As I have just mentioned, that the first generation calcium channel blockers have got a short duration of action, rapid onset, and they act predominantly on the L type of calcium channel blocker. We need something which will also act on the T, so as to reduce the reflex tachycardia, which results because of the reduction of the SA node and AV node conduction. So, what are the drawbacks of old calcium channel blockers? They are rapid and short acting and less selectivity to L channels on blood vessels and heart. They do not block T channels in heart. So there is an increased heart rate and pulse rate, which what we call as reflex tachycardia, increased sympathetic nerve activity. And this increases the myocardial oxygen consumption and increases the risk of future CV events. So this is the drawback of the older calcium channel blocker. As I said, amlodipine is technically third generation as with azilnidipine, but azilnidipine in addition has got an effect on the T type of calcium channels. The amlodipine will lead to increased reflex tachycardia because of norepinephrine release, whereas azilnidipine, which is a dual L and T type calcium channel blocker, it will not allow this reflex tachycardia. The SA node slowing because of azilnidipine will not be countered by a increased norepinephrine level because it blocks the norepinephrine release from the neurons also. So in effect, we will get a heart rate which is the same as baseline or maybe reduced, and a dilated blood vessel, which will cause a reduction in blood pressure without a significant change in the heart rate. So the heart rate variability will also be less. So azilnidipine blocks cardiac T channels also. It also blocks the neuronal T channels. It reduces reflex tachycardia. So there is a reduced heart rate and blood pressure variability. And because the T channels in brain are also blocked by azilnidipine, the sympathetic nervous system activity is also reduced with azilnidipine. So this offers better cardioprotection. So here the norepinephrine release is inhibited by azilnidipine by blockage of T channels. It leads to vasodilatation as a class effect of all calcium channel blockers. It reduces renin secretion. It reduces myocardial contractility, which is again the class effect of all calcium channel blockers. It increases the glomerular filtration rate. It reduces arterial stiffness and improves the endothelial function. Now, again, this slide repeats the same thing. The blockage of L channels will reduce blood pressure will by a vasodilatory effect, and it will reduce the blood pressure by the negative inotropic effect of the calcium channel blockade, which occurs with conventional as well as azilnidipine. However, the additional effect of blockage of T channels in the neurons will lead to sympatholytic effect, reduction in blood pressure, suppression of reflex tachycardia, and increase in the GFR. And blockage of T channels in the heart will cause suppression of reflex tachycardia. So definitely the uh, molecule azilnidipine has got benefits with respect to conventional calcium channel blockers when we take into consideration the reflex tachycardia, heart rate variability, and blood pressure variability. Now, when a patient is being treated with azilnidipine, 16 milligrams, uh, the reduction of morning blood pressure and pulse rate is significant. This is a study which included over 5,000 patients and was conducted over a period of 16 weeks, and it showed that the change in blood pressure, systolic blood pressure, was significant at the end of 16 weeks, reduction of almost 20 millimeters of mercury. Diastolic blood pressure also almost 10 millimeters of mercury reduction. And the heart rate, which was baseline 73, came down to 69. So that is because azilnidipine does not allow reflex tachycardia by its mechanism, additional mechanism of blockage of T type of calcium channel blockers. Also, there was a comparative study of acylnidipine 8 or 16 versus amlodipine 2.5 or 5 in 100 patients each group, and the reduction in the systolic blood pressure and diastolic blood pressure with acylnidipine was significantly more as compared to amlodipine. Similarly, there is a better heart rate reduction compared to cilnidipine because cilnidipine, as I previously mentioned, is a L and N type of calcium channel blocker, but it does not have significant effect on the T calcium channels. So azilnidipine causes a significant change in heart rate after 16 weeks compared to cilnidipine. Now, this slide again reinforces the fact that azilnidipine shows lesser reflex tachycardia as compared to amlodipine. And this is by mechanism of reduction in adrenaline, noradrenaline, dopamine release from the neurons. So reduced catecholamines and improved baroreceptor sensitivity offers better cardio protection uh, via azilnidipine as compared to amlodipine. Now, in patients with congestive heart failure, this reduction in sympathetic overactivity plays a very significant role. And this study, which compares cilnidipine and azilnidipine, shows that sympathetic activity is lesser in patients with who are undergoing treatment with azilnidipine as compared to cilnidipine. Now, apart from antihypertensive effects, its blockage of T channels resulting in lesser reflex tachycardia or even bradycardia. There are other pleiotropic effects of azilnidipine which are not observed with other calcium channel blockers. So this is one important effect. Azilnidipine shows better anti-atherosclerotic effect. The lipophilicity of azilnidipine is 17 times as compared to amlodipine, and this results in a high lipoprotein binding activity and stronger anti-arteriosclerotic effect. These are the parameters on which these activities were tested: the HSCRP, IL-6, TNF alpha, adenopectin, 8-isoprostane, and BNP. And there was a significant reduction in the activity of all these parameters of inflammation and atherosclerosis. Azelnidipine also reduces arterial stiffness and improves endothelial function. The intima media thickness ratio is reduced significantly with azelnidipine as compared to other calcium channel blockers. Azelnidipine has got a positive effect on the LV function, especially the diastolic dysfunction element. If we see this study where azelnidipine 16 milligrams was administered and 232 patients were included in this study, uh, of which 160 received azelnidipine and 72 received amlodipine. It was found that the parameters of diastolic function, that is the deceleration time, E velocity, and E by E ratio, amlodipine. Also, the other pleiotropic effect of azelnidipine is its anti-inflammatory action and antioxidant effect. So this is a study which compared azelnidipine 16 milligrams with amlodipine 5 milligrams for 16 weeks. And this study also showed that azelnidipine reduces oxidative stress by reducing central and peripheral sympathetic activity. I have mentioned at the very beginning that azelnidipine is a L and T type blocker, whereas cilnidipine is L and N type blocker with not much effect on the T channels. There are other calcium channel blockers. I just mentioned about benidipine also, which is predominantly L type, and to a certain extent has effects on the T and N calcium channels also. Ifomedipine is another evolving calcium channel blocker which has got effect on the L and T calcium channel blockers. The clinical significance, which I mentioned, the effect on T type of calcium channels, the blockage of T type of calcium channel blockers is reduction in the heart and pulse rate, the reduction of glomerular pressure, increased GFR, and reduction in aldosterone secretion. So these are the benefits which we get by treating the patient with azelnidipine as compared to amlodipine. To summarize, hypertension is one of the key factors for high CV mortality. Calcium channel blockers are one of the mainstay for treatment of hypertension. Old generation, that is selective L-type calcium channel blockers, are devoid of cardiac T-channel blockade, thus have potential risk of reflex tachycardia. Azelnidipine, due to dual L and T blockade, show lesser reflex tachycardia. Azelnidipine also inhibits sympathetic nerve hyperactivity, thus giving better cardiovascular protection. The additional pleiotropic effects are anti-atherosclerotic, antioxidant, and anti-inflammatory actions, which provide better CV protection compared to the older calcium channel blockers. So, azelnidipine definitely holds promise for the future treatment of hypertension, especially because of the dual L and T blockade. I thank you all for your kind attention.
Thank you, Dr. Dharmadikari, for a wonderful presentation. We'll come back to you during the discussion mode. So now I would like to welcome Dr. Chafekar for his presentation, renal aspects of azelnidipine.
Good evening, everybody. Dr. Dharmadikari has very nicely summarized regarding the latest information about azelnidipine, as well as the relationship of calcium channel blockers vis-a-vis the heart, as well as what are the advantages of azelnidipine as a new molecule which is available to us. Now, the job which has been entrusted to me is to talk about the renal aspects of calcium channel blockers and to talk about how is azelnidipine useful from the renal perspective. Now, I first of all thank IPCA for this CME, and let us get on with the information regarding the kidneys. You must excuse me if there is a repetition of a few slides for the simple reason that some information has to be given in continuum. So therefore, some information would be repeated. So in this presentation, all of you know about the hypertension, which Dr. Dharmadhikari has already told you the figures. I'm going to tell you about some facts about hypertension in India, and then some aspect of physiology of calcium channels, and the classification has already been discussed. And then we'll talk about renal aspects of SLED. Just to set the ball rolling, we know that it's a lifestyle disorder. What is the Indian prevalence? The overall prevalence of hypertension in India is about 29.8%. So it's important for us to know that 1/3 of the Indian population could be suffering from essential hypertension. Now, the world figures have already been told to you by Dr. Dharmadhikari. Almost 1.6 billion patients are estimated to have been suffering from hypertension by the year 2025. And remember that the other point which we should remember is that we as a medical community are not doing a very good job as far as control of blood pressure in our hypertensive patients is concerned. Even in the United States, there are publications to show that the awareness about hypertension and its effects is poor, to the tune of almost 60 to 70%. And the compliance to therapy is not adequate. It's almost to the tune of 50%. Even if you are compliant, the control of blood pressure after good compliance is also to the tune of about 30 to 40%. Practically, it means that with such staggering figures of hypertensive individuals all over the world, we are not really doing a good job as far as control of blood pressure is concerned. So therefore, naturally, we need better and better molecules to control the blood pressure as well as to prevent end organ damage. So these are some facts about hypertension in India. It has already been mentioned that it's a principal driver of cardiovascular disease in India. Almost 1 in every 3 Indian adults is affected by hypertension. Now, I already mentioned that awareness about hypertension, treatment and compliance and the control of blood pressure is poor. Many of our patients also have what is called as pre-hypertension, which is now called as stage 1 hypertension as per the American guidelines. All of us know that Indians develop coronary heart disease at a younger age, maybe less than 40 years, irrespective of their geography or expatriate status. And there is enough affirmation that blood pressure levels between 130 to 139 systolic and 80 to 89 diastolic in the Indian population, which is almost like stage 1 hypertension. It can cause substantial cardiovascular complications, stroke, premature death, and I must also mention the morbidity related to kidney disease. So when we talk of organ damage, which is related to high blood pressure, cardiac-wise, you know that you can have coronary heart disease, left ventricular hypertrophy, congestive heart failure, peripheral vascular disease, transient ischemic attacks and strokes in the brain, retinopathy, and of course, chronic kidney disease. So these are the principal organs which can be affected, leading to increased mortality and morbidity. We also know that hypertension is very closely related to chronic kidney disease, and progression of chronic kidney disease in our patients is definitely related to poorly controlled blood pressure. Now, the chronic kidney disease can progress due to various reasons, but we also know that almost 80 to 90% patients with chronic kidney disease have hypertension, and in many of these individuals, the blood pressure is not controlled, leading to early progression of chronic kidney disease. Now, uncontrolled hypertension is the risk factor for developing CKD because it increases the intraglomerular pressure, causing progressive glomerulosclerosis and progressive fall in GFR. Whenever there is glomerular sclerosis, there is of course proteinuria. Proteinuria is a marker of kidney damage. So therefore, progressive renal disease can exacerbate uncontrolled hypertension. So it is very clearly seen that if you have a hypertensive individual and the blood pressure is not controlled, then he is more prone to have chronic kidney disease. And if you have a patient with chronic kidney disease of any etiology, and if the patient's blood pressure is not controlled, again, that can lead to progression of his chronic kidney disease, leading to end-stage renal disease very early. Blood pressure and kidneys are closely related, and there is a lot of renal dysregulation which occurs in almost all patients with hypertension. Remember that there is something called as renal autoregulation whenever we are talking of the blood pressure control. All of us are aware that the renin-angiotensin-aldosterone system is based in the kidney, and kidneys have a great role in controlling or in causing the pathophysiology of high blood pressure. All of us know that broadly hypertension can be classified as a renin-mediated hypertension, and we know that renin comes from the juxtaglomerular apparatus, which is located in the kidney. And the other type of hypertension which can be classified is volume-mediated hypertension. Again, we know that the intravascular volume and sodium status is very closely related to the kidney. So therefore, kidney and hypertension are very, very closely related. And here comes the role of the afferent and the efferent nerves, which affect the afferent and the efferent arterioles in the kidney. So we know that each glomerulus has got an afferent arteriole, then there is a tuft of the glomerular capillaries, and then we have the efferent arteriole. And we know that the glomerular filtration ultimately results in urine formation. So normally you have what is called as normal renal autoregulation, and in the afferent arterioles we have the L and T calcium channels. In the efferent arterioles we have predominantly the T calcium channels. And remember that intraglomerular pressure is some result of the effect of the afferent channels, afferent arterioles, as well as the efferent arterioles. And the afferent arterioles are controlled by the L and T calcium channels through the afferent nerves. And whenever you have hypertension, then in the initial stages, you can have renal autoregulation, which is compensated. That means there is contraction of the afferent arteriole. There is also some contraction of the efferent arteriole, and there is hardly any change in the intraglomerular pressure. However, when you have a hypertensive patient with decompensated renal autoregulation, then you will have what is called as afferent arteriolar vasodilatation, resulting in increase in the intraglomerular pressure. At the same time, there is efferent arteriolar vasoconstriction. So again, it causes back pressure, and therefore, because there is a marked increase in the intraglomerular pressure, you have progressive damage to the glomeruli, resulting in progressive chronic kidney disease. So renal autoregulation in hypertension, again, it is shown here in a schematic way. Remember that the L and T type of calcium channels which are present in the afferent arteriole, they are responsible for vasodilatation. But if you have only vasodilatation and vasoconstriction on the other side, which is the efferent arteriole, then you have a rise in the intraglomerular pressure. So again, this is which is controlled by the L and T type of calcium channels. And because there is increase in the intraglomerular pressure, you will have a reduction in GFR and increase in proteinuria. This particular CME is about calcium channel blockers and about azanidipine. So let us talk in some details about the physiology of calcium channels. Now remember that opening of the voltage-dependent calcium channels permits influx of calcium across the plasma membrane, and Increase in the intracellular calcium is responsible for the increase in the vascular tone, peripheral vascular resistance, and the increase in the blood pressure. So this is the basic physiology of the calcium channels, and this is again the basic physiology which is addressed when you are talking of calcium channel blockade. Now this particular information has already been given to you. These are the types of calcium channels, but the L type of calcium channels are predominantly present in the skeletal muscle, heart, brain, retina, and the afferent arteriole of the kidney. The blockade of L type of calcium channels results in dilation of systemic vasculature and reduction in blood pressure. T type of calcium channels are present in the heart, kidney, brain, and the nervous system. There are some advantageous effects of blockade of T type of calcium channels. In kidneys, it reduces proteinuria, improves chances of kidney survival, and in the heart, Dr. Dharmadhikar has already told you about the importance of blockade of T channels. N channels are mainly present in the brain. It results in reduction in vasoconstriction, heart rate, and aldosterone secretion. So again, a schematic diagram about distribution of L type and combined L and T type of calcium channels in the large and small vessels, again resulting in reduction in calcium entry and affecting the blood pressure. So this is just a repetition of the previous slide. What happens if you talk about the L channels, and what happens if you talk about the other type of calcium channels and its effects. I'm not going to repeat that. Now, as far as the kidneys are concerned, if you talk of the T channels, then T channels are responsible for increase in the renin secretion, again resulting in increase in the aldosterone secretion. So therefore, it's important for us to know that this is closely linked to the pathophysiology of hypertension. This is how the calcium channel blockers have evolved over a period of time. And we know that cilnidipine is available to us since 1996 and azilnidipine is available since 2003. Please remember that in India, azilnidipine is available only recently. But you have basically two types of calcium channels blockers. But before that, this is how CCBs have evolved. So L type of calcium channel blockers were widely used for the treatment of hypertension. The first generation drug nifedipine was introduced in the 60s, but the drug activated sympathetic tone due to its rapid onset of vasodilatation action. The second generation partly allowed the reduction of sympathetic reflex by designing slow release formulation of the first generation drugs or by newly developing slow acting drugs. Later, amlodipine was introduced as a third generation, which exhibits longer half-life in plasma than the second generation agents. But some pharmacokinetic and pharmacodynamic improvements do not always evade the sympathetic reflex induced by the hypotensive action of the L type of calcium channel blockers. This is again a repeat slide which I will not elaborate on, but basically azilnidipine acts mainly on the L and T type of calcium channels. Now, the important thing for us to remember is that the evidences showed that aldosterone contributes to endothelial dysfunction, arterial hypertension. Remember that aldosterone is an extremely important mechanism, especially in difficult to control blood pressure. And we are using mineralocorticoid antagonists, which are basically aldosterone blockers in all cases of resistant hypertension. So aldosterone contributes to arterial hypertension, endothelial dysfunction, left ventricular hypertrophy. It also contributes to renal fibrosis. And therefore, it's important for us to remember that any drug which has an anti-aldosterone effect is going to be very, very vital for two reasons. One, it is going to have some organ protective effect. And second, it is also going to contribute to control of blood pressure. So the anti-aldosterone effect is extremely important. Again, I'm not going to elaborate about the mechanism of action of all CCBs in hypertension. And at present, where do CCBs stand as far as hypertension management is concerned? Now, according to various guidelines, CCBs can be first-line therapy for hypertension. We all of us know that there is a rule called as the ABCD rule. And whenever you have an elderly hypertensive individual who is more than 60 years old, then the drug of choice is CD. C means a calcium channel blocker and D means a diuretic. If you have a younger individual who is less than 60 years old, then the drug of choice will be A and B, which is the angiotensin receptor blocker or the beta blocker. Now, this is called as the ABCD rule. But remember that now in many of the guidelines, especially in stage 2 hypertension, people are advocating combination therapy with CCBs and ARBs together because we want to control the blood pressure as early as possible. Now, the advantages of various calcium channel blockers and disadvantages have already been mentioned. What is the impact of all CCBs as far as renal function is concerned? Traditionally, conventional CCBs like nifedipine and amlodipine, they increase the GFR and renal blood flow by dilating the afferent arteriole preferentially, whereby glomerular hypertension and subsequent renal injury are expected to ensue unless the systemic blood pressure is sufficiently controlled. That means normally the CCBs are going to have a positive effect as far as GFR is concerned, provided the blood pressure is very well controlled. But CCBs like azelnipine, they have a vasodilator action on both the afferent and efferent arterioles. Therefore, there is subsequent reduction in the glomerular pressure over a long period of time, resulting in reduction in proteinuria, retarding the progression of CKD, because the driver for progression of CKD is fall in GFR and increase in proteinuria. And of course, it means that it improves kidney survival. So the basic classification of CCBs is dihydropyridine group, which have a greater selectivity for vascular smooth muscle and myocardium and less negative inotropic activity. And then you have the non-dihydropyridine group. They have greater selectivity for myocardium than for the vascular smooth muscle. Now, as far as the nephrology practice is concerned, the dihydropyridine group of type of CCBs are used more commonly. But in some patients where we want to reduce proteinuria, we are also using the non-dihydropyridine type of CCBs like diltiazem. And otherwise, we are of course using the dihydropyridine as per the generations which are given here. And they have a strong vasodilator action. Why there is a need for new CCBs? Because blockade of only the L type of channels results in various problems like reflex tachycardia and increase in the glomerular pressure over a period of time. And therefore, the blockade of T channels is very, very important, and that can lead to more of renoprotection. Now remember that the old generation CCBs did not block the T channels also of the adrenal glands. And because it did not block the T channels of the adrenal glands, again, there was increase in the angiotensin II activity, resulting in hyperreninemic state. So we know that some of the hypertension is renin mediated, and we need some amount of anti-renin drugs. So therefore, it's important for us to know about azelnipine and the drugs which have got effects also on the T channels. So azelnipine is a long-acting dihydropyridine type of CCB, acts on both L and T type of calcium channels, strong affinity to vascular smooth muscle. So it is retained at cellular receptors even after clearance from blood, and therefore it has got the antihypertensive action is there over a longer period of time. It also shows a gradual fall in blood pressure and therefore does not induce reflex tachycardia. It has an effect on the large vessels as well as the micro vessels, and therefore it provides better renoprotection. The chemical structure is as mentioned here. It is composed of a racemic mixture containing a 1:1 ratio of active R enantiomer and inactive S enantiomer. Now, the mechanism of action of azelnipine is already mentioned. It shows a 17-fold higher lipophilicity than amlodipine. So therefore, it is probably more active, more effective as compared to amlodipine. And as far as the cardiac mechanisms are concerned, already it has been elaborated on. What happens in the kidney? So this is a pictorial diagram about the L channels and the T channels shown here at the afferent arteriolar level, the T channels at the efferent arteriolar level. Predominantly, the action is of L type of channels at the afferent arteriole, and you can see the blockade of L type of calcium channels at the afferent arteriole through the nerve terminal, and the blockade of T type of channels at the efferent arteriole through the nerve terminal, resulting in obvious advantageous effect and obvious renoprotective effect. Now, we also told you about the blockade in the adrenal glands. So this is again a repeat slide, which I don't want to read. Now, let us look at some of the studies. Dr. Dharmadekari already mentioned about the at-home study. The important thing about at-home study was that it is one of the largest studies carried out in the world with home blood pressure monitoring. We know that in our patients with hypertension, nowadays we are advocating home blood pressure monitoring, just as we advocate blood sugar monitoring with a glucometer in diabetic patients. And home blood pressure monitoring is a good tool as far as long-term control of blood pressure is concerned. So this particular study, which has already been elaborated upon, importance is that it is one of the largest studies as far as home blood pressure monitoring is concerned, and it showed the effectiveness of this particular drug over a period of 16 weeks, and it showed that there was a substantial reduction in blood pressure, which was clinically significant and which was important for both systolic and diastolic blood pressure, showing that there was a 24-hour BP reduction. And the importance was that the morning blood pressure surge was controlled. We know that a lot of accidents happen in the morning because of the morning blood pressure surge. So therefore, it was important to know that the morning blood pressure also reduced, and the CV events and the stroke events was also reduced. As compared to amlodipine, the drug is more effective. So comparison to amlodipine, it showed that there was a greater reduction and it was more stable over a period of 24 hours with lesser side effects. Now, heart rate, I will not elaborate on because it has already been mentioned that the advantages of controlling the heart rate are very, very obvious. Most of the cardiologists will tell you that controlling heart rate is as important for longevity as any other measure which you would do otherwise. What about effect of azellipine in hypertensive CKD patients? Now, this is a very interesting study. Azellipine has antioxidative properties, and these may contribute to the beneficial effects of the drug in reducing these biomarkers. So there are two biomarkers which have been studied in this trial. Now, what they did was they selected a few patients with CKD, and in these CKD patients, it was a randomized study, and what they did was they studied a urinary biomarker called liver type fatty acid binding protein in patients with CKD and hypertension. A randomized study, 30 hypertensive CKD patients, comparison between amlodipine 5 milligrams once a day and azellipine 16 milligrams once a day, duration of 6 months, and the endpoints of the study were change in blood pressure and heart rate and change in the urinary protein excretion of two biomarkers, 8-OHDG and urinary L-FABP levels measured 3 and 6 months post-treatment. And what they found was these two urinary biomarkers, there was a significant reduction in these biomarkers, suggesting that the oxidative stress as far as the kidney is concerned was reduced in these CKD patients. At the same time, they also studied proteinuria in these patients with CKD. And again, they found that as compared to amlodipine, azellipine offers significant reduction in urine protein excretion as compared to amlo because there was no change as far as reduction in proteinuria was concerned. So therefore, the urinary biomarkers which are related to the oxidative stress are reduced in the azellipine group, and the control of blood pressure was comparable. It has some renoprotective effects in hypertensive patients with mild CKD. So these are the advantages as far as using this particular drug is concerned in CKD. Now, all of us know that uric acid is a very important biomarker in patients with heart disease as well as in patients with kidney disease. And most of the patients with CKD, they will have hyperuricemia. It is now said that in a conservative management of chronic kidney disease, we also advocate controlling the uric acid levels. What is the effect of azanidipine on uric acid metabolism in patients with essential hypertension? We know that most of the patients with essential hypertension also have hyperuricemia. In fact, there is a study to show that if you have a patient who did not have hypertension, but he had hyperuricemia, then the chances of that patient developing hypertension in the future are as high as 60%. So therefore, there's a very close relationship between hyperuricemia and essential hypertension. So 72 patients, azanidipine 8 or 16 milligrams per day. In 22 cases out of 72 patients, difference with CCB was switched to azanidipine. BP was measured and biochemical parameters were evaluated. And there was some evidence to show that there was some reduction in uric acid levels, and this could have resulted in reduction in progression of renal disease also. Underlining the fact that uric acid levels can also be controlled with azanidipine. Remember that there is only one other antihypertensive drug which has some effect to uric acid, which is losartan. And in clinical practice, if I have a patient with hyperuricemia and hypertension, then I would prefer losartan because it has got a uricosuric effect. So therefore, here we have one more drug, which is a CCB, which has some effect also on the urinary, some effect on the uric acid level. What happens in diabetics? We know that most of the diabetics, they have proteinuria, and we want to control proteinuria in these patients. Currently, we are using ARBs or ACE inhibitors to control proteinuria. Any diabetic who develops hypertension, he is going to have progression to CKD very fast. So we need to control blood pressure in most of our diabetic patients very, very aggressively to prevent progression of kidney disease. So in diabetic patients, what happens to urinary albumin excretion? This was studied in a trial called as BOAT-2 study. We know that azanidipine blocks the T-type of calcium channels and reduces proteinuria. So this study was done in diabetic patients. And here you can see that there was a reduction in the urinary albumin excretion from 274 milligrams to 121 milligrams in the azanidipine group. But in the amlodipine group, in fact, there was a rise in the urinary protein excretion, indicating that there was no effect as far as proteinuria was concerned, even in diabetic patients. And the last important point which I want to highlight is about aldosterone and the anti-aldosterone activity as far as patients, hypertensive patients with type 2 diabetes is concerned. 35 patients on a CCB, and they were switched to azanidipine over a period of 6 months. Initially, they were on amlo, benidipine, cilnidipine, or nifedipine, and then they were switched to amlodipine. And what was studied was the aldosterone level and the PAI1 activity, which is again related to the renin-angiotensin-aldosterone axis. Now here again, important thing to remember was that after switching to azanidipine, there was some reduction in the aldosterone levels. And we have already told you about what is the importance of reduction in the aldosterone levels as far as organ protection is concerned, basically also related to the kidneys. And anti-aldosterone drugs are very important drugs in our therapeutic armamentarium. So this is about the clinical evidences which are very important in renal patients. One is about the urinary biomarkers. Second is about reduction in proteinuria. Third is about reduction in uric acid levels. And fourth is about reduction in the aldosterone levels. So these are the advantages of this particular molecule. Now, putting guidelines into practice, it's important for us to know that the algorithm for treatment of hypertension, JNC8 is of course It's old, but it suggested that CCBs could be first line therapy in people who are more than 60 years old. And remember that in patients with CKD, we are very comfortable with using CCBs because they do not cause fall in GFR or they do not increase the proteinuria. So we are very comfortable with reduction with using CCBs in patients with CKD. However, most of the guidelines will also tell you that CCBs is class 1A treatment for management of hypertension as per the European Society of Cardiology. So in our practice, CCBs are important as far as antihypertensive medications are concerned. And now we have a newer CCB called azellitidine. It has got the obvious advantages related to the heart and the kidney. And therefore, we must remember that this is a new drug. If selected properly and used in chosen patients properly, you can have good renoprotective effect, as well as you can also have good cardioprotective with good control of blood pressure, leading to longevity, as well as leading to less morbidity and mortality and organ protection is concerned. Thank you for your attention.
Thank you, Dr. Shafekar, for your wonderful presentation. So I think it was very elaborate. I'll thank Dr. Dharmadikari as well. Now we will go to the discussion part, which is a very interesting part of this particular discussion. So we'll start with the question for Dr. Dharmadikari first, and then we'll come to you. So Dr. Dharmadikari, if you can unmute your mic. Yes.
Done.
Yes. So the first question is that we have seen you have presented the Mumbai cohort study, which actually showed that even a small increase in the blood pressure, systolic blood pressure, they caused an increase in stroke and MI. Even 120 to 130, there was an increase in MI and stroke, and even the systolic is increasing from 130 to 140, there was an increase. Now going to the ACCHA hypertension guideline, they are advocating calcium channel blocker as the first line treatment of hypertension. Now, in this context, how do you view CCBs as a first line treatment in hypertension? And how do you specifically see azellitidine in this particular category as a first line treatment?
As you have correctly said, that the ACC-AHA guidelines mention calcium channel blockers as the first line treatment for hypertension. Azellitidine is a evolving molecule. Evolving in the sense that people are yet to know about it. So azellitidine definitely is a promising molecule which will improve the treatment of hypertension, not only
Yes.
with respect to the control of blood pressure, but also with respect to control of other complications of hypertension.
Okay.
Because of its additional T channel blocking effects, it will reduce the other complications of hypertension and it definitely holds promise for the future.
Okay. Now you have talked about the role of the T channels in the cardiovascular system. So beneficial role of the T channels. Now, what are the drawbacks? Right now, old CCPs, they have some drawbacks. So what are the drawbacks? And specifically, if I say, how does azellitidine fare against the older CCBs and also cilnidipine? How do you see that in that respect? Because there's benadipine in the market. Now, amlodipine was already there. Benadipine was there. Cilnidipine is there. And then we have azellitidine. So how do you view that? If you're treating first line for hypertension, how do you view azellitidine in that particular respect?
Well, until now, the first line therapy amongst the calcium channel blockers was
Yes.
amlodipine and in certain resistant hypertension cases, nifedipine.
Hmm.
Cilnidipine has been introduced before azellitidine and it
Hmm.
was becoming popular because of its effects on the N-type calcium channels. However, with the advent of azellitidine, I believe that azellitidine will become the primary drug of choice amongst the
Okay.
calcium channel blockers to treat hypertensive patients, especially because of its effect on the reflex tachycardia. You are asking
Okay.
specific advantages over older
Yes.
calcium channel blockers.
Yes.
So there was all the calcium channel blockers depress the SNO. So they cause primarily a reduction in the heart rate.
Okay.
However, With the older calcium channel blockers, there would be increased norepinephrine release and increased sympathetic activity, and this would lead to reflex tachycardia. So that is not seen with azilnidipine. That can be seen with cilnidipine. There can be reflex tachycardia with cilnidipine, but not with azilnidipine.
Okay.
So with the control on this reflex tachycardia, the heart rate variability is less, blood pressure variability is less, myocardial oxygen demand is less. So this is especially advantageous in patients with ischemic heart disease, in whom tachycardia is not very desirable.
Okay. Also, the early morning surge also, I think
Yes,
azithromycin has a beneficial
yes,
effect
yes,
on the early morning surge, which is responsible for maximum number of strokes and MI.
definitely.
Yes.
Can I
So
comment on this particular point?
yes, yes, yes.
Indranil.
Yes, yes, definitely. Your presentation, it particular slide was there which talked about early morning surge. So going back to you. So your comments.
No, I think your question basically was a clinical question, probably.
Yeah.
With Aniruddha has already mentioned about what are the advantages of Zenlipine and why it will come into the forefront of our therapy.
Yes. Yes.
Now, the question which is there in every physician's mind is that currently, whatever we are using, how are you going to place this vis-a-vis other calcium channel blockers?
Yes.
So, how I look at it is like this. One is that every calcium channel blocker has got its place in therapy. But if you have a patient, from my perspective, if you have a patient with, say, proteinuria, and we know that proteinuria is now a target as far as reduction is concerned, because if you reduce proteinuria, then you are going to benefit the kidneys. So therefore, it's important for us to remember that any drug besides control of blood pressure, if it has got some additional advantages, so he has already mentioned about tachycardia, but the other advantages which I already mentioned in my presentation would be reduction in uric acid, then the
Yes.
reduction in proteinuria, maintenance of GFR, etc., etc. That is seen as a additional advantage. So probably you have to choose your patients properly. You may say that, well, if my hypertensive patient does not have proteinuria, then I have a choice of using any CCB. That is also correct. But to my mind, cilnidipine is a weaker antihypertensive, and we have to use the dose which is high if I want to control the blood pressure, especially in stage 2 to stage 3. So if I want to use cilnidipine, I cannot use it more than stage 2 hypertension because it's a weaker antihypertensive. As far as benidipine and ifonidipine are concerned, we are using it. The problem is again related to the proteinuria reduction, not much robust evidence as far as these two molecules are concerned. And the problem of edema feet should also be addressed, because all our patients who are on amlodipine or nifedipine, they have edema. And then it's a nightmare to sort out the edema if the patient has cardiac failure or if the patient has renal failure. On one side, you need the calcium channel blocker. On the other side, you also have to deal with edema. So if there is some evidence that azithromycin also reduces peripheral edema, that also is going to be a big advantage over other CCBs.
Regarding the uric acid part, I just want to just one clarification. Like losartan, we used to say also has uric acidic effect, and in the studies we see it has been compared to placebo, but it is not decreasing the uric acid per se, but it is keeping it neutral, whereas placebo is increasing it. So in the case of azilnazepine, does it cause a decrease in uric acid level, or it is neutral compared to placebo?
No, the study clearly showed that there was a reduction in uric acid level.
Okay.
However, remember that it is a small study. It's
Okay.
the number of patients is small, so it cannot be generalized. But the clear message is there that all hypertensive patients have high uric acid levels. You always tell them to reduce the uric acid by diet control. But
Okay.
if you are using a drug which is going to have some additional advantages, then probably that's going to be beneficial. As far as losartan is concerned, yes, the effect is uricosuriya, but that effect is also important in the sense that uricosuriya ultimately will cause a fall in uric acid levels.
Thank you very much, Dr. Shafikar. Now, Going to Dr. Dharmakadigarige. So we have a question for you, and it is regarding heart failure. So we have been talking about heart failure and the reflex tachycardia. I mean, the role of beta blockers in heart failure. Now, do you see any benefit of azanlidipine in a patient with hypertension with heart failure with respect to other CCBs? So, like Dr. Shafiq has said, that heart failure edema is a concern, pedal edema is a concern. Amlodipine is not used. Azanlidipine. Will you use azanlidipine in that particular case?
Yes, definitely. I would prefer if the hypertensive patient is in heart failure and he is already
Yes.
on calcium channel blockers, then
Yes.
I would prefer to shift the patient to equivalent dosage of azanlidipine. From amlodipine,
Okay.
say if it is 5 milligrams, I will shift to azanlidipine 16 milligrams. And
Hmm.
that is because the sympathetic overactivity of amlodipine is far more than with azanlidipine. And that sympathetic overactivity is harmful in patient of congestive heart failure.
Okay.
Uh, the azanlidipine also improves the glomerular filtration rate as compared to amlodipine. It reduces the renin levels as compared to amlodipine. So I would definitely prefer to shift the patient from uh, amlodipine to azanlidipine. See, using beta blockers as the first line therapy in the treatment of heart failure is a different thing because it is not just the reduction in the heart rate or reduction of myocardial contractility. There are other mechanisms of beta blockers by which they are beneficial in the treatment of congestive heart failure. Those mechanisms have not been clarified about azanlidipine. So I would not use them in place of beta blockers for treatment of heart failure. However, I will shift a patient of amlodipine or other calcium channel blockers to azanlidipine if he is already on some CCB and now in heart failure.
So, in case of heart failure, is there any change in your preference in case of preserved or reduced, or you in both cases you will use azanlidipine?
In both, in the cases with preserved systolic function, that is predominantly diastolic dysfunction, and in those patients with the reduced ejection fraction.
Okay.
In both the cases, I use azanlidipine because the relaxation parameters, myocardial relaxation parameters, also show improvement with azanlidipine as compared to amlodipine. The
Okay.
deceleration time is reduced. The
Okay.
IVRT, the isovolumic relaxation time is reduced with
Yes.
azanlidipine.
Okay. Okay. Now, if you come to the treatment of say reduced ejection fraction, you are using a beta blocker, say metoprolol, then you are using azanlidipine, and there is a because azanlidipine, as we know, has an action on the SA node as well. So in these cases, would you also use ivabradine, or you'd be keep it reserved? You will not use it so much. So what is the scenario in
I
this
am
case?
already using beta blocker. I am already
Okay.
using azilnidipine. I don't find any need for ivabradine
Okay.
because it is not the tachycardia which is
Okay.
my consideration. Because in heart failure, the tachycardia is reflex tachycardia
Yes.
to
Mhm.
compensate for the reduction in the stroke volume and to
Yes.
maintain the cardiac output. There is
Mm.
tachycardia. So I would not like to kill that tachycardia by giving ivabradine because then I would not know the real clinical situation of the patient. If there is no tachycardia, I cannot be complacent that, oh, the patient is stable now, that heart rate has come down, so he has
Okay.
settled. No. So I would not like to use evaporating.
Okay. Thank you very much, Dr. Dharmadikari. Now going to Dr. Shafekar. Dr. Shafekar, I have a question. I mean, now definitely it always crops into my mind. Now I have you, you're a specialist, so I would like to ask this question specifically for you. In case of diabetic kidney disease as well as non-diabetic kidney disease, in both the scenarios, what do you pay more attention to? Is it the EGFR or the proteinuria, or the both, or how do you correlate these two?
If you look at the new classification of CKD recently published, there's a clear cut on the y-axis. We have albumin urea as one of the parameters divided into
Hmm.
A1, A2, and A3, starting from mild, moderate, and severe albumin urea. It's not called proteinuria any longer. And on the other axis, you have GFR. So the combination of the two is going to drive the progression of kidney disease, and not only one. So you are going to have various permutations and combinations in both diabetic kidney disease and in non-diabetic kidney. So for example, you will have a situation where the GFR is on the lower side, but hardly any proteinuria or albuminuria. You might have a situation where there is gross albuminuria, but normal GFR, and various such permutations and combinations. So it is now thought that if you have a person who has got very, very minimal proteinuria, but a mild fall in GFR, he is going to do better as compared to a person who is going to have both increase in albuminuria and a fall in GFR. So greater the albuminuria and greater the fall in GFR, worse prognosis will be there depending on the clinical situation. So that is called as the red zone or the orange zone as far as the CKD classification is concerned. So you need to look at both and not only one. And depending on the clinical situation, you need to find out what you can do to reduce albuminuria if it is gross, or what you can do to preserve GFR if it is falling, even if the proteinuria is not there.
So is there any specific difference between when you look at DKD and NDKD? Is there a difference between these two situations?
So if the question is about proteinuria and eGFR versus DKD and NDKD is concerned, remember that in DKD, proteinuria is the driver as far as progression of kidney disease is concerned. What has been seen is that whenever a diabetic kidney disease patient develops progressive proteinuria and ultimately has nephrotic range proteinuria, the progression to chronic kidney disease and end-stage renal disease is very fast, even if the person is non-hypertensive. If the person is hypertensive, his kidneys are going to fail much earlier. So imagine a diabetic individual who had mild proteinuria and no hypertension. He goes on to have gross proteinuria and no hypertension. In that particular situation, proteinuria is the driving factor as far as progression of kidney disease is concerned. However, please remember that with progression of CKD, there is fall in proteinuria. As the GFR starts falling, the proteinuria also would fall. That means if the GFR has fallen from say 50 to 40, and your proteinuria initially was gross, because of fall in GFR, the proteinuria might fall. But in that case, the control of blood pressure becomes very, very important. And if you don't control the blood pressure in the hypertensive patient, again, the progression of kidney disease is very, very fast. So in a nutshell, in a diabetic kidney disease, proteinuria in the beginning is very, very important for you to control. As hypertension sets in, the proteinuria would reduce and the control of blood pressure becomes more significant for you to preserve the GFR. Now in non-diabetic CKD patients, it is basically the both. But initially remember that proteinuria is a target of control of GFR. So therefore, you must use a drug which reduces proteinuria in a hypertensive patient. And if you demonstrate that the proteinuria is reduced from say 1.5 grams to 500 milligrams in that particular individual, you are going to do a great service to the patient because that is going to have a very good renoprotective effect. So that is in a nutshell the difference between diabetic and non-diabetic kidney disease vis-a-vis proteinuria and GFR is concerned.
Thank you, Dr. Shafikar. We'll come back to you again. So next question is for Dr. Dharmadhikari. Sir, the next question is basically how do you view azanilidipine in a case of diabetic hypertension, and also if the patient does diastolic dysfunction, how do you view azanilidipine compared to the other calcium channel blockers? You have to unmute. You're muted. Dr. Dharmadhikari, you're muted. Yeah.
As a class, the calcium channel blockers do not have a significant effect on the diabetic control, as
Yes.
against beta blockers and diuretics, which have cause a deranged in normal individuals, deranged GTT, or in diabetic individuals, uncontrolled diabetes. So that is not the case with calcium channel blockers. Now, amongst the calcium channel blockers, when we are treating patients with who are diabetic hypertensive, then I would prefer azelnidipine over amlodipine because, of course, Dr. Trafficker has very well elucidated the advantages of azelnidipine over other calcium channel blockers in diabetic patients. It definitely I would prefer to give azelnidipine as the first line therapy as compared to other calcium channel blockers in diabetics who are diagnosed to have hypertension because of
Okay.
so many
Can I
renoprotective
comment on
effects.
that? Yeah.
Yes. Yes.
Now, from our perspective, we know that in diabetics, the first drug of choice is an ARB. Let us make it very clear because
Yes.
we
Yes.
want to prevent
Yes.
proteinuria. There are some studies to show that even if you don't have proteinuria, is there a role of an ARB to prevent onset of proteinuria? Because we know that proteinuria is a sinister event as far as diabetic is concerned. But many of the diabetics, they are not controlled with an ARB. In that case, we don't want to use beta blockers. The second addition drug is, of course, a calcium channel blocker. And amongst the calcium channel blockers, if you have any drug which reduces proteinuria, then it's going to be an add-on effect. So you just look at the CCB which you want to use and look at the evidence whether there is a reduction in proteinuria, and you would get the answer.
Okay. Thank you, Dr. Chafekar. Now, the next question is basically for you. If you are using azelnidipine or if you are using a calcium channel blocker in CKD, uh, would you use azilidipine equally in non-diabetic as well as diabetic, or are the choices different when you use a CCB?
I don't think that I would use it differently in a non-diabetic or a diabetic CKD for the simple reason that the basic premise of using a CCB is control of blood pressure. If my blood pressure is controlled very well without any side effects, then I think I have achieved quite a lot, because I already told you in my presentation that the blood pressure control is dismal as far as the world population is concerned.
Hmm.
Only 40% of people are really controlled and rest of them are not controlled for whatever reasons. So if I am able to achieve blood pressure control with whatever drug, CCB or any other drug, I'm happy about it. In both diabetic and non-diabetic CKD, I don't mind using azelnidipine because it is going to give me a longer half-life, 16 hours blood pressure control, and it is a monotherapy. That means a single pill to be taken in the morning. So therefore, I think that I don't mind using it in both non-diabetic and diabetic CKD. As far as diabetics are concerned, we have already told you about the advantages in
Yes,
diabetic
yes.
patients. So I don't need to repeat that.
Okay. Thank you very much, Dr. Chafekar. Now, Dr. Dharmadikari, we have a question. We have seen that azilidipine has a very good effect on the and as an anti-atherosclerotic drug. So, with respect to other CCBs. So, have you in your practice observed any specific benefits if you're seeing a CT-NG or coronary calcium scoring in these patients? Have you seen, or in future you want to do some studies or you want to study this particular aspect, and how beneficial is it?
Yes, as you rightly mentioned in the second part of your question, in future, because
Yes.
azilnidipine is a pretty new molecule.
Yes.
Studies which demonstrate the antioxidative, anti-atherosclerotic mechanisms, other pleiotropic benefits of azilnidipine, they consist of a very small subset of patients.
Okay.
We definitely need to undertake larger studies to establish the anti-atherosclerotic benefits of azilnidipine. Like I mentioned in one of my slides, the intima media thickness
Yes.
ratio of
Yes. Yes.
carotid arteries. Azilnidipine definitely has a positive impact on the IMT, but the number of patients included in this study were not very significant. So we need to undertake larger studies in the future to reinforce our knowledge of pleiotropic benefits of azilnidipine with respect to other calcium channel blockers. But at the moment, I wouldn't dare to say that yes, I have found advantage of azilipine in reducing the CT calcium scoring or the stenosis. As of now, it's difficult to say.
Sir, what about non-dippers? Have you seen any benefit, what is your idea that can, if you somebody finds you an ABPM, if you have a non-dipper, would you use azilidipine with combination azilsartan or something like that? Would you use this combination in the future?
Azilipine, yes, definitely. Achil Sartan, I have an experience of using in a significant number of patients, but I have practically not found it beneficial over the present olmesartan molecule. But azilnidipine, because of the studies which demonstrate the benefit to reduce the morning rise of blood pressure or the morning rise of heart rate, I would definitely shift the patients who require a better 24-hour control of blood pressure with reduced heart rate and blood pressure variability. I would definitely shift them to azilnidipine.
Okay.
Just my comment on this. I
Yes.
think we should also look at the data of central aortic pressure
Yes.
as far as the ABPM data is concerned. And we should be doing more studies with the augmentation index and the other parameters as far as the central aortic pressures are concerned. And then you would know what are the advantages of these drugs.
Dr. Shafakar, one question has come for the audience specifically for you. The question is that in end-stage renal failure patients on dialysis, would you use azithromycin to control uncontrolled hypertension?
Yes, so if a patient is on dialysis, then which are the drugs which we prefer as far
Yes.
as antihypertensive action is concerned? I already mentioned that we nephrologists are very comfortable with most of the CCBs for whatever advantages we have. The other drugs, ACE inhibitors and ARBs, we are a bit skeptical because of the problem of hyperkalemia. So therefore, we don't really prefer unless we are pushed to the wall. As far as beta blockers are concerned, remember that most of the beta blockers are dialysable except for carvedilol. So therefore, if you want to use a beta blocker in a dialysis patient, prefer carvedilol. The other drugs which are used are alpha blockers and centrally acting drugs like reserpine or moxonidine. Now remember that in dialysis patients, there is a big problem of intravascular volume reduction post-dialysis. And these people will have postural fall of blood pressure. So if the patient is on alpha blocker or a centrally acting drug, then there would be a problem of postural drop of blood pressure with syncopal attacks. So therefore, obviously, we are very comfortable with the use of CCBs. And if I can control the blood pressure with a single pill on a non-dialysis day, we remember that we don't give antihypertensive drugs on the dialysis day just before dialysis. After dialysis, we are giving the antihypertensive drug to control for the rest of the number of hours. But on a non-dialysis day, if I have a CCB which controls blood pressure throughout the day for the next 24 hours, then it is definitely an advantage.
Thank you. Thank you, Dr. Shafakar. As we can see, I think this drug is a paradise for, I would say, is a very good choice of drug, both for the cardiologist and the nephrologist point of view. Now we'll go to Dr. Dharmadagari. Sir, are you there? Can you please unmute, Dr. Dharmadagari?
Yes.
Yes, as you said, this drug is a very good weapon in the armamentarium for both the cardiologist and the nephrologist. So, what
Yes.
is your message? What is your key message to the if you are launching? Is there so many drugs in the market? There, I mean, in the calcium channel blocker space, there are 4 or 5 calcium channel blockers which are there. What is your message to the cardiologists who would like to prescribe a calcium channel blocker with respect to azilnidipine?
Well, if we look at the present calcium channel blockers available in the market, we have first generation nifedipine, the second generation benidipine, as well as efimidipine, the third generation amlodipine, azilnidipine, and the fourth generation sildenafil, of which nifedipine and amlodipine are being extensively used. I think the Usage of cilnidipine is increasing despite was what Dr. Safekar correctly pointed out. Cilnidipine is not a very potent antihypertensive agent. That is my personal experience, and I have stopped using cilnidipine since long. With regards to benidipine, again, it is still not very potent antihypertensive. You cannot compare it with amlodipine. Forget about nifedipine. Ifenadipine is also in the market since a couple of years, but not very extensively used. I would definitely give a chance to azilnidipine in place of amlodipine, with the advantages we have discussed extensively over the past 90 minutes or so now. I would definitely place azilnidipine as the first line therapy for treatment of antihypertensive, especially those patients in whom we choose to start calcium channel blocker. It definitely
Okay.
has got a bright future.
Thank you, Dr. Dharmadegadi. Now going to Dr. Chafekar, your key
Can
message
we
for the
stop now,
yes,
Indranail? It's
yes,
one and a
yes.
half hours now.
Okay, okay, okay. I think we're coming to the end of this program, but before that, I would like to take key message from Dr. Chafekar for the
Yeah.
nephrologist.
So from the practical point of view, I think it's important to say if you have a hypertensive patient, essential hypertension, and if you have a younger individual, the guidelines are very clear which antihypertensive to use without any comorbidities. No cardiac problem, no renal problem, only hypertension. The guidelines are very, very clear. More than 60 years, CCBs and the beta blockers, sorry, diuretics. And less than 60 years, it's ARBs or beta blockers. These are the guidelines which are generally followed. But in stage 2 hypertension, I think combination of drugs is now advocated, which again we need to think about. As far as use of choice of antihypertensive is concerned, whenever you have a comorbidity, for example, proteinuria, hyperuricemia, cardiac problem, renal insufficiency, that is the time where you need to choose your drug correctly. So we know that ARBs also have renoprotective effect. They are to be used very, very judiciously in the early stages of chronic kidney disease. We know that there are some drugs which reduce proteinuria. We know that there are some, we need to control the uric acid levels, etc., etc. So choose your antihypertensive medication correctly, especially in patients who have comorbidities, and that is the time where you are going to benefit the patient as far as organ protection is concerned.
Thank you very much. Thank you very much, Dr. Chafekar. Thank you, Dr. Dharmadegadi, for your excellent presentations and also the way you answered all the questions. Thank you very much. And with that, like we'd like to come to the end of this program. We'll hope to meet soon with some new topics, new discussions, and in a different forum. Thank you very much.